Now let's talk about lower GI bleeds. And as we talked about in the first video, that's blood that comes out at the bottom usually. And it presents in a couple of different ways. You could have melena, which is black stool, which is partially digested blood, hematochezia, which is blood mixed in the stool, or just frank blood coming out. And anatomically, what we're looking at here is lower GI bleeds tend to come from below the ligament of Treitz. So that's the jejunum, the ileum, and all of the colon. So the causes of lower GI bleeds are many, they're plenty. And the relative frequency of them, the numbers are all over the place, so just take these as kind of an approximation. Upper GI bleeds could be a source, right? If you have a pretty frank upper GI bleed, it could go all the way through and come out the bottom. You could also have it coming from the jejunum, but a small amount comes from there. Colitis, diverticular bleeding is a big cause. Angiodysplasias can cause it. Anal rectal diseases, that is things like hemorrhoids and fissures. You could also have it post procedural. If someone had a polyp that was removed, that could cause lower GI bleeding. Colon cancer you need to think of, and coagulopathy as well. So let's start talking about diverticular bleeds first. And most of the diverticula are going to occur in the sigmoid and the descending colon. But most of the bleeding ones are going to be up here on the right side, in the ascending colon. One of the big risk factors for diverticuli formation is constipation. And though the bleeding could be pretty impressive, most of them resolve spontaneously. Most angiodysplasias occur in the cecum and the ascending colon. What happens is the smooth muscle around it tends to get contracted, and then that causes the veins to get dilated and tortuous, and then you get these arteriovenous malformations forming, which then tend to bleed. Next, we move on to colitis, which comes in 3 varieties: ischemic, inflammatory, and infectious. We'll look at each one of these in turn. Ischemic colitis obviously has to do with the blood flow to the colon. And so normally you have a good amount of blood flow. So in conditions with poor blood flow, like arrhythmia, CHF, hypovolemia, and sepsis, you don't get as much blood going to the colon. And this reduces the circulation there, and it really affects the watershed areas of the splenic flexure and the sigmoid colon. These are areas that have poor collateral circulation. And so your treatment would be to treat, obviously, the underlying cause, but also bowel arrest so that bowel doesn't need as much blood flow, IV fluids to get increased flow to there, and antibiotics to prevent any infection from translocation of bacteria. And I should let you know, this is not the same as mesenteric ischemia. This is ischemic colitis. So inflammatory colitis comes in 2 varieties. We got the Crohn's and the ulcerative colitis. Crohn's, you'll remember, will have the classic skip lesions, whereas ulcerative colitis tends to be more continuous. Both of them will cause rectal bleeding. Usually the patients will know about this and be able to tell you if this is like their normal flare-ups are, or if it's more severe. And then finally, we have infectious colitis. So I'm going to give you my terrible mnemonic to help you remember that. And it's, if a bear poops in the woods and nobody's there to hear it, does it make a sound? Look, he's having bloody poop, actually. Unfortunately, we don't know the answer because he's not alone. Bears tend to go near campsites. And at the campsite, there's a whole bunch of people near a campfire. And so, what are the things that give you bloody diarrhea? Well, you can obviously have Campylobacter, right? This little fish here is Salmonella, because it's a salmon. And then this one here is Shigella. Look, it's a salmon with a shag haircut. Remember that Shigella is closely related to Salmonella. And it also causes seizures, especially in little kids, so that's why I put the little shaking fish there. This one's a stretch, I'll admit. Broccoli sounds like E. coli or E. coli, right? E. coli 0157 can cause bloody diarrhea. And entamoeba, here's an amoeba around the campfire, can also cause bloody diarrhea. So these are the common causes of bloody diarrhea for this poor bear. Yes, I know this is a terrible mnemonic, but you'll probably remember it now. Remember, right? Campylobacter, Salmonella, Shigella, E. coli 157. and entamoeba, E. coli 0157. You can also have anal rectal diseases that cause bleeding, like internal and external hemorrhoids, as well as fissures. But one point that you should remember is just because you see a hemorrhoid or a fissure, it doesn't mean that there can't be some more proximal cause to the lower GI bleeding. So if they have hemorrhoids but they're bleeding a lot, then it's probably not the hemorrhoids. Hemorrhoids bleed a little bit, but they don't tend to bleed a lot. You can also get bleeding after a polypectomy. And these will be either immediate or delayed. The immediate ones tend to be arterial and will need some sort of intervention to stop the bleeding. So you're probably going to need to call GI. And the delayed ones tend to be venous, and those will usually resolve spontaneously. And last but not least, we can't forget the lovely and the beautiful aortoenteric fistula. And so here you'll see we have an aorta with an aneurysm in it, very close to the small bowel, and fistula could form, which starts first with a small herald bleed, and then proceeds, as you can imagine, because it involves the aorta, into a massive hemorrhage. When this involves an aorta that has an aneurysm that has not been repaired yet, we call that primary. If this is an aorta that has been repaired, so it has a stent in place, then we call it a secondary bleed. Now these are vascular emergencies, so you need to get vascular surgery down there as soon as you suspect this. So lower GI bleed plus a history of a AAA, either new or even repaired, equals a call to your vascular surgeons. Alright, so now we're going to move on to treatment. So as with any sick patient that comes in the emergency department, start with your primary survey, intubate them if they need to, give them supplemental oxygen or supplement their breathing if necessary, and you know circulation is going to be a problem. So 2 large bore IVs, supplemental oxygen, and put them on a cardiac monitor. And in fact, as with any GI bleeder, get an EKG if you're able to, because anemic people tend to become ischemic and will have cardiac changes from that. And you're going to get a bunch of blood tests, notably a CBC, CMP, coags, and a type-in screen or type-in cross, depending how badly this person's bleeding and how likely you think they're going to need transfusion. And you may want to consider an NG tube, as we talked about in the upper GI video. There might be an upper GI source, and this will help you in that case. You're going to end up asking a lot of things on history, but a couple of important things are, what kind of bleeding is this? Is this melena, which maybe makes you think maybe this is an upper sore, a GI bleed? Is it frank blood, which makes you think that maybe it's a lower blood? Are they on anything that might make them bleed? Blood thinner type medications? Do they have a history of tics or polyps? Do they have a history of AFib that's going to make you think of ischemic colitis or a AAA, right, for an enteroaortic fistula? So an NG tube is one way to locate the source of the bleeding. If it's a lower source, though, another thing you could try using is colonoscopy. And if they're stable, you might let them take some polyethylene glycol first to clear out all the poop from in there so they get a better view. And it has been shown to shorten the length of stays in the hospital. You do need a somewhat brisk bleed in order to see that, so maybe instead you have a little slower bleed. So for these slower bleeds, you can do a tagged Rbc scan. So you take some red blood cells, you tag them with some nuclear material, you inject that into the patient. 2 hours later, you scan them, and then you can pick up bleeds that are a little bit slower bleeds, 0.1 to 0.5 milliliters per minute. And you can also use angiography to locate bleeds, and it can find bleeds at about 0.5 to 1 milliliter per minute. And the other benefit with angiography is that you could squirt vasopressin right there at the source of the bleeding. Or you could embolize the vessel if needed. So it's not only diagnostic, it could also be good for treating. And this works better in arterial bleeds. So it works great in tics. Doesn't always work so good with AVMs. There are complications with this. With anything that you use contrast, you have the possibility of contrast reactions, kidney injury, and there's always a possibility that you might dissect the vessel that you're using to go up to find the bleeding. And if that fails, or if any of this fails, or the patient rebleeds, or the bleeding is really severe, then it's time to call your surgeons. If they can find the source of the bleeding, they may do a hemicolectomy, and if they can't, or a partial colectomy, And if they can't find the bleeding source, then they might have to take out the entire colon, a total colectomy. So in review, some potential people you may need to call includes IR if we need angiography, GI if you need endoscopy, surgery for a partial or a total colectomy, and finally vascular surgery if you need an entero-aortic fistula repair. And then the last thing we need to talk about is the disposition. Where are these patients going to go? Are there any who could go home? Sure. Patients with hemorrhoids or fistulas, or maybe even like Crohn's disease or ulcerative colitis that are stable, they have good vital signs, their hemoglobin is good, and you have good follow-up for them, and maybe even observed them for a while, because you have to make sure with these hemorrhoids and fistulas that it's not really a more proximal source, and they do fine, and then you feel comfortable sending them home. So some of them can go home. The ones that are stable but not hemorrhoids, maybe they need to come in so that they can be scoped by GI non-emergently. The ones who are unstable but they're not bleeding should probably go to the ICU. And those who are still bleeding should probably go to the OR or IR suite. Now these are just rules of thumb. Each patient is different and each hospital is different, so talk to your consultants, talk to your patient, and you decide how stable you feel the patient is before you make your disposition. So this was our quick run through lower GI bleeding. There's of course more detail for each one of these diseases, but it was a good overview. So thank you for watching. Goodbye.